Hello, and welcome to ID Talk, answers from an infectious disease expert. I'm Dr. Sean Elliott, a pediatric infectious disease specialist with Tucson Medical Center, professor emeritus of pediatrics at the University of Arizona College of Medicine, and medical director of infectious diseases and immunizations at the Arizona chapter of the American Academy of Pediatrics. This podcast has been created to answer questions from our chapter's members about the COVID-19 pandemic and pretty much everything else infectious disease or infection prevention. This is the week of September 18th. Recently back from a lovely 2-week vacation away, so thank you for your patience and waiting for me to get back. Hopefully all of you are doing well and had a chance to escape or will have a chance to escape for vacation in the next couple weeks or months or so. Once again, some great questions getting back into COVID land as things heat up just a little bit. Yes, indeed, we're starting to see increase in numbers of SARS-CoV-2 infections in pediatrics and adults across the country. Certainly that is following trends established in other parts of the world as well. And as we'll talk about in just a little bit, some new subvariants are coming through. All these are still Omicron. All these are still fairly infectious, but not significantly severe in terms of disease onset, at least in terms of lower respiratory tract disease. Other things that we're seeing in the community continue to be a smattering of rhino/enterovirus with secondary complications, including bacterial pneumonias, mastoiditis, certainly purulent acute otitis media, and the odd occasional adenovirus and the odd occasional GI virus as well, including norovirus and rotavirus. So with that as a sort of general overview, let's launch into the questions. And the first one is, what are the thoughts on COVID and viral prevention nasal sprays? And then some specific products are listed. In general, nasal sprays in the COVID-19 pandemic have been a really great idea, but in practice, not yet proven to be highly effective, although there are some products which have actually worked quite well. Big caveat, however, is that no nasal sprays either preventative against SARS-CoV-2 or otherwise prevented viral entry. None of those are officially yet approved by the FDA in the United States. However, they are approved and in use in many other parts of the world. First part of that, nasal vaccines. So this kind of makes sense, right? Just as with all the thoughts of oral vaccines and other modes of delivery, it makes sense that one can create an antigenic response by doing an inhaled or a nasal spray, very similar to the live attenuated influenza vaccine, intranasal, and that technology has certainly been adopted in other parts of the world, notably and successfully in Russia, which actually took its Sputnik V vaccine, one of the first adenovirus-based live attenuated vaccines, and also turned it into a nasal delivery system with apparently reported good outcomes in terms of seroprotective response, efficacy, lasting protective response, and safety. India also has led the way in a intranasal vaccine, again with a live attenuator product. And as of the time of this podcast, there are 16 intranasal vaccine products out in the world specifically targeting SARS-CoV-2. All of them appear to be a modification of a live attenuated vaccine, just like the live attenuated influenza vaccine. So I would assume the same safety precautions would apply to those as well as they do to the influenza vaccine, i.e. young people without an intact immune system, older people with immunodeficiency or immunosuppression, anybody with some sort of chronic respiratory illness, including chronic asthma on daily controlled medications. These are all patients who should not receive any of those products. But as noted here in the States, it's kind of a non-issue because we don't have them tested or approved for use in the general public. Now, the other products then are a combination of nitric oxide-based products, xylitol products, alcohol-based products, iodine, etc., and so forth. The majority of these fall into the category of preventing entry or protective barrier establishment within the nasal mucosa. Makes a lot of sense, right? Because SARS-CoV-2, like other respiratory viruses, gets its entry into the human body typically through nasal mucosa, right? It's where we all get infected by influenza, rhinovirus, RSV, and of course SARS-CoV-2. So a lot of these products then establish some sort of hostile environment within the nasopharynx and respiratory epithelium, which either prevents binding of a respiratory virus like SARS-CoV-2 or specifically inhibits or dysregulates that binding so that it cannot establish a toehold and create secondary infection, leading to the disease we know of as COVID-19. In theory, this sounds fantastic, and in initial studies, this has shown a variable response, specifically that of nitric oxide, has been established to increase the clearance of viruses because it does have a known or putative antiviral effect through the activity of nitric oxide on viral replication. That's the science, and that has been demonstrated in vitro, meaning in the test tube, I guess, is the term you might use, and in some animal studies, but there are very few human studies to prove the efficacy of a product like nitric oxide. Specific to that, there have been several small studies, no more than 300 patients, which have shown a definite benefit in decreasing SARS-CoV-2 replication as evidenced by onset or development of disease. However, other studies, specifically looking in vitro about the effect of nitric oxide on SARS-CoV-2 replication, have not shown any reliable effect. So the takeaway from this is the studies are mixed, and there are certainly no large population-based human studies to support the reliable use of nitric oxide products in inhibiting or preventing COVID-19 after exposure. The same goes then for other products as well, including the iodines, the alcohols, azilastine. There's one question mark still remaining about the xylitol. And I'm sure many of you recall the xylitol-based chewing gum as a way to prevent or mitigate everything from dental cavities to sinopulmonary infections such as otitis media and mastoiditis and things like that. There is, again, a theoretic and in vitro demonstrated antiviral effect of xylitol itself. But, and this held true for the xylitol-based chewing gums as well, the amount, the concentration of xylitol needed to establish that benefit is very hard to establish in any oral or nasal delivery mechanism. So yes, in concept, yes, in the science, it sounds fantastic, but in practicality, it's not likely to have proven benefit going forward. However, stay tuned to this podcast. It is very likely that the science will continue and human studies will commence, and that we may have either more evidence to support use or to say, nice idea, it didn't work. But right now, the human studies in large are lacking. So thanks for that great question. It helped me educate or re-educate myself about the specific local effects of a lot of these products. Next question, also COVID related. As there are fewer COVID tests happening in the healthcare setting, what is the best resource to try and stay informed about the COVID burden, the prevalence, the incidence in the community? And as a related question, is there any wastewater surveillance being performed in Arizona? Well, so yes, as you all know, with the end of the declaration of public health emergency on May 11th, many of the areas of active reporting decreased, certainly in terms of active surveillance. However, at least in Arizona and through the Arizona Department of Health Services, positive COVID cases are still reported. Now, this is a positive reporting mechanism. It absolutely cannot capture the true denominator, or the true burden of disease occurring daily in Arizona, because how many patients may be sick and did not get tested, how many patients had a positive test in the outpatient setting, at home, in the office, that was not reported. But those reports being obtained in a healthcare setting with a reporting mechanism to Arizona Department of Health Services are reporting those, and you can track those on the Arizona Department of Health Services website. And it specifically reports them cases per week for the state, breaks it down further to county and even by zip code. And you can see the numbers, if you look at over the last several weeks, the numbers have been creeping up, actually now for the last 5, 6, 7 weeks or so. So yeah, it is not the best indicator, but it is an indicator if you accept the fact that it's a sampling with sampling error. The sickest of the sick will go to a healthcare setting to be tested, to be reported. But if one considers that those numbers creeping up suggest the community prevalence is also creeping up, then I think we can take some reliable information from that. So again, go to the Arizona Department of Health Services website, search COVID, or you can just Google search, COVID numbers in Arizona, and that part of the website will come right up, and you can check it out versus, compared to your zip code to your county. In terms of wastewater surveillance, again, fantastic technology whose time has come and whose benefit has definitely been proven by the COVID-19 pandemic. Unfortunately, it is resource heavy to perform that because one needs a lab which does or can do the molecular diagnostics, and more importantly, one has to have access to the wastewater sampling, which is perhaps not the most pleasant job in the entire world. So laboratory technicians, research assistants, understandably would rather not do that, and unless it's a formalized arrangement, it's not likely to have non-commercial based wastewater surveillance occurring. And that is true in Arizona as well. Certainly the University of Arizona for a while was sampling wastewater from its dorms as a fabulous indicator of disease burden on campus, but that has stopped as of actually several months ago, almost a half year ago. And at least I'm not aware of other organizations performing active surveillance in Arizona at this time. That is true from the CDC as well. There are several wastewater surveillance programs occurring in large metropolitan areas and actually including in Washington, D.C., but of course it'd be very difficult to extend those numbers and predict anything occurring in Arizona. So if and or when we reach another surge, and hopefully that is not going to happen, that we'll have our sort of winter epidemic numbers, which I think is what we're starting to lean into. But if that prediction falls flat on its face and we have a major surge with a brand new subvariant or a new variant, SARS-CoV-2, then I expect that we'll have an increase in surveillance occurring once again. Okay, next question. When will they authorize free COVID test kits? Ooh, yeah, probably not ever. Again, unless the Armageddon occurs and we get back to another surge event. But as mentioned before, May 11th saw the end of the Public Health Declaration of Emergency, and with that, the end of free test kits being provided through health departments. All health departments, including local county health departments in Arizona, advertised in the website, hey, free test kits available for your picking up until supplies run out. It being now September and May being a good while ago, those supplies have run out. So not likely to find free test kits available through the health departments, unfortunately, and it is not likely that one will see that federal program start up again where you can contact the feds and have them send test kits. That said, Medicare and those patients who are receiving Medicare for their insurance are guaranteed access to free test kits through September of 2024. So another year, which is fantastic. And again, I wonder what test kits they're using, and I wonder about the shelf stability of those test kits, but that at least is what is officially published and released by the federal government. All the rest of us can quibble with our local, either private or other access insurance providers and request test kits to be provided free of charge, or at least for a significantly reduced rate. But I do not anticipate a national program of free test kits for everybody to start up again unless, again, we reach a brand new surge with a brand new virus and hit, again, the huge numbers we had before. Okay. Variants, the variants of COVID. So what is the newest variant of concern? How do we stay current on all those? Actually, believe it or not, one of the best sources of staying current are the local media, because of course this is newsworthy. Oh dear, it's the BA 2.86 come down from Canada, watch out. And actually New York Times has done some very nice either editorials and or news items about once a month or so, giving an update on what the variants are that are out there. However, if one really wants to know and does not trust the media, tongue-in-cheek, to give them a source of medical and scientific information, then you too can search cdc.gov as well as local reporting mechanisms to see what the variant strains are that are circulating in the United States and more specifically in your state or county of origin. And again, I keep forgetting we have people tuning in from outside of Arizona, so everything I say applies to you and your local health departments as well. For those in Arizona, we are still predominantly the XBB.1.5. That is a good third to even 45% of new isolates that have been typed. And that's good because the new vaccines, new mRNA vaccines coming out from Pfizer and Moderna that just got approved and are likely going to be released either by the time you're listening to this or even before. So the new vaccines are out there specifically targeting XBB.1.5 with cross protection against all the other subvariants that are out there and emerging as well. So what are the others? And there are two others you need to know about, which are currently rising or emerging. The first is EG.5, nicknamed ERIS, E-R-I-S. And the second one is the BA.2.86, which has been nicknamed Pirola, P-I-R-O-L-A. I don't know where they get these, but it's very cool. They're very colorful names, far better than Kraken. That was just a nasty. Both the EG.5 and the BA.2.86 are notable for having significant increases in mutations, again in the spike protein, that binding construct which allows the virus to attach to respiratory epithelium. And theoretically, because of that increased mutational changes in the spike protein, to have immune escape to older immunity and older vaccines. However, the initial studies from both Pfizer and Moderna, so grain of salt, but others as well, suggest that the new vaccine coming out against the XBB.1.5 has still significant cross protection against the EG5 and the BA2.86, which fantastic, great, that's wonderful. Also, and important, and this has been true for all the preceding subvariants of Omicron, even as they become more mutated and more potentially infectious, the virulence or the disease associated with these viruses has not changed. So we are still seeing what we typically have been seeing with even the most recent subvariants of Omicron, being an upper respiratory tract illness, which is hard to distinguish from a common cold or upper respiratory tract infection, or even from severe seasonal allergies. And for everyone who themselves personally is suffering from allergies, great, you know exactly what I'm talking about. It's the headache, the stuffy, the congestion, the sore throat, the itchy, scratchy, tickle, dry cough. All these absolutely can be environmental allergen based, but also could be due to our dear friend SARS-CoV-2 subvariant, etc., and so forth. So that's the majority of COVID-19 that is being seen. There are those patients, however, with, again, underlying comorbidities or who have co-infection with other viruses or bacteria who are presenting through the emergency departments and requiring admission, typically for oxygen need, for hypoxia. And in pediatrics, again, we continue to see the COVID croup. So a lot of our patients have that croup-like cough and an O2 requirement and a requirement for dexamethasone and requirement many times for racemic epinephrine and other respiratory support. So that is still what has been occurring in pediatrics from SARS-CoV-2 subvariants of the Omicron, and that has not changed even with the EG5 and the BA.2.86. So a common question, which has not been asked of this podcast this week, but it's been asked of me in practice, in fact, just about 30 minutes ago as I was rounding through the PICU, should we be getting the new COVID booster vaccine, the new one against the XBB.1.5? And my answer is absolutely yes, but the timing, I think, remains to be seen. So the vaccines are just being released right now. We're just starting to see an increase in surge. If an individual has been fully vaccinated before and has had COVID-19 recently, then their immunity is going to be quite superb, and including superb against the emerging subvariants. However, if one's actual wild-type COVID-19 infection occurred more than a year ago or so, or even 1 or 2 years ago, then, number one, their immunity, natural immunity, is waning. And also, number two, their immunity may be to another variant or subvariant to which the newest subvariants, the EG5 and BA2.86, have immune escape tendencies. So if you are fully vaccinated but had, or your patient is fully vaccinated but had wild-type infection a long time ago, at least a year or two or so ago, then yes, they for sure should get the newest vaccines to update their immunity and prevent immune escape of the newest subvariants. If, however, one is fully vaccinated and has had infection in the last year or so, then you can probably wait for just a little bit, but not too long. So, of course, I'm in full support of the newest COVID vaccines, boosters. It's just the timing is the big question. So, that is what I have to say about that, COVID-19. Our last question then is changing into other vaccine land, and this has to do with the newest pediatric pneumococcal vaccines, both the 15-valent or the 20-valent, the Prevnar 20. And the question is that, could I please clarify which of those two products should children receive? Well, I'm not going to recommend a product over another, but I will note scientifically both products, the 15-valent and the 20-valent, so we're talking Merck and Pfizer here, have significant superior efficacy against three new emerging serotypes that are likely causing any invasive or even superficial pneumococcal disease that you're seeing in your practice. And those serotypes are 3, 22F, and 33F. I actually have several patients who recently have had pneumococcal disease despite being fully vaccinated with the Prevnar 13, appropriately so. And so it is likely that they're suffering invasive infection from one of those three new serotypes. The 15 and the 20-valent vaccines available to you to purchase for your practices do cover those three invasive strains. Obviously, the 20-valent covers 5 additional ones, but it is unclear if there's clinical significance for those remaining 5 valents serotypes, and whether vaccinating with that product provides any additional benefit. But we also don't know what we don't know. And as we do better preventing at least 15 of those invasive serotypes, nature has this phenomenon called serotype replacement, which means that the remaining 5 could also emerge and cause more disease. So in terms then of seroprotective efficacy, certainly your vaccine reps will be happy to show you their own data demonstrating superior efficacy of one versus the other. It is true that the Merck product, the 15-valent, does have longer lasting and higher protective efficacy against serotype 3 significantly, and to a somewhat lesser extent 22F and 33F compared to the Prevnar 20. But whether that is clinically significant, I think, remains to be seen. So long story short, in answer to the question, I'm not going to clarify anything at all, but as is typical, in talking with your vaccine reps, whatever contract you can sign or deal you can create to get one versus the other, your children, your patients are going to be very well protected with whichever product you end up purchasing to deliver to them. And I think that's the key thing here. Both benefit to our pediatric patients, but also by extension to their adult and geriatric adult family members who also are at risk for invasive pneumococcal disease. Everyone will benefit from use of either of these products, and I'm just super pleased that both are out there and both have really good protective efficacy regardless of any way you cut it. So there you go, that's pneumococcal disease. Other than that, I think we're sort of seeing so far a fairly typical early fall lead up to the winter months. RSV is starting to make its way known. There were no questions this week about RSV and the newest products, but nirsevimab, or Beyfortus for those who like the product name, has been officially approved, and I imagine that hospital pharmacy and therapeutics committees, such as my hospitals, are in the process of approving that product to give to newborns as we enter RSV season window. And it is going to be, I hope, an exciting couple years as we see the impact of this newest monoclonal antibody against RSV, which has great protective efficacy, and the recent approval of the RSV vaccine against pregnant women, all on top of the previously approved RSV vaccine for patients ages 60 and older. So it would be fabulous to see all these products roll out together and do a significant preventive impact on RSV burden in the community. I don't anticipate we'll see that impact this year because it's too late, and rollout is going to take a while to get kids protected. But hopefully by next RSV season, we will be seeing a decrease in the number of at-risk and other patients admitted to hospital and admitted to pediatric ICUs with severe RSV disease. So please stay tuned for that as well. And if you and your practice are on the fence about delivering the newest monoclonal antibody against RSV, the nirsevimab, I strongly encourage you to consider that positively, to get the product, to administer it, because the numbers and the safety profile look fantastic. Again, I know that's an endorsement and it's not meant to be a specific product, but just in terms of the science and the risk to children who are at risk for bad RSV disease, we've got an answer, folks, and this is a way to go about decreasing risk to our very susceptible pediatric patients. So with that, thank you as always for listening to ID Talk. Arizona AAP members can submit questions for future episodes to covid@azaap.org. The Arizona AAP would like to acknowledge the generous support of this podcast by the Arizona Department of Health Services through the Title V Maternal and Child Health Services Block Grant funding. For more information and resources related to COVID-19 in Arizona, or to learn how to become a member, please visit us at azaap.org. And for everybody tuning in from outside of Arizona, thank you for doing so. It's lovely to have a broad listening audience. And feel free to send us questions as well. We're happy to take any and all. Just send them on in. In the meantime, and until next time, keep hanging in there, folks. Fight the good fight. Get those vaccines that come in, as I know we all wish to. And I appreciate all of you. Thanks so much for listening.